let's start with giant cell arteritis. And giant cell arteritis, or GCA, is considered the most common form of primary systemic vasculitis in the United States. Patients with active GCA may experience temporal headaches, jaw claudication, and this means jaw pain and fatigue while eating food, fever, weight loss, painless vision loss or double vision, arm or leg fatigue during activities called claudication. They may have elevated inflammatory markers called sedimentation rate or C-reactive protein. And then lastly, they may have other condition in addition to the giant cell arteritis called PMR or polymyalgia rheumatica, and usually will cause stiffness and pain in the shoulders and the hips. After induction therapy, we reassess the patient, and while remission, we expect giant cell arteritis patient not to have the same temporal headaches they had in the beginning and during the active vasculitis, not to have the jaw claudication, not to have the fever and the weight loss. We expect them to have normal inflammatory markers and no polymyalgia symptoms. However, they may continue to have vision loss and arm and leg claudication during activities, even during remission. And this is what we call it chronic organ damage. So this is something could be irreversible with our induction therapy. At any time during remission, could be a month after achieving remission, could be few months, could be on or off therapy. Relapses do happen in GCA patient, and this is more than 50% of cases. And at the time of the relapse or flare, patient, they may experience again the same kind of headaches they had in the beginning, the same jaw claudication they had during the active vasculitis. They may have new or worsening vision loss in addition to whatever they ended up during the remission. And their inflammatory markers, they may be elevated again. But this is with exceptions, sometimes if they are on medication called tocilizumab, so we cannot rely 100% on the inflammatory markers, and this is one of the disadvantages of this medication. Second, Takayasu arteritis patients, and this is another rare form of large vessel vasculitis, mainly occurs in young female patients. During active Takayasu arteritis patient, they may have bruits, and bruits, it means abnormal sounds over the arteries due to abnormal blood flow. They may have asymmetric blood pressure between both arms and lower extremities and the legs. They may have elevated inflammatory markers, areas of stenosis, narrowing or dilation, aneurysms of their arteries on the images. After induction therapy and while in remission, they may continue to have the same sound, the same bruits over the arteries. They may continue to have the asymmetric blood pressure between the arms and the legs. They may continue to have the extremity claudication during activity, and they may continue to have the stenosis and the aneurysm on their images. These are all chronic damage, so it could be also irreversible with our induction therapy. The same thing with the giant cell arteritis patients. At any time during remission, they may experience relapse on or off treatment. And then again, they will end up with a new area of stenosis or aneurysm in their arteries on the images. Their inflammatory markers will be abnormal again if they were elevated in the beginning. They may have new areas of vessels involvement during relapse or flare. Then moving to medium vessel vasculitis, and the most common one is polyarteritis nodosa, though this is something rare, we don't see a lot because of the hepatitis B vaccination nowadays. But patients with polyarteritis nodosa during active disease may experience neuropathy, may experience skin rash and ulcers, may have fever, weight loss, may have elevated inflammatory markers, sedimentation rate, and CRP. In addition, on their images, we may find also stenosis or aneurysms of their arteries. After induction therapy, we reassess. Hopefully, they are in remission. But during the remission, they may continue to have neuropathy and areas of stenosis or aneurysm of their arteries. This is what we call it chronic organ damage, something irreversible with our induction therapy. Relapses are not very common in polyarteritis nodosa, may be reported between 5 to 20% of the cases, but could happen anytime. during remission, they may experience again new neuropathy, new skin rash, new fever, weight loss, elevated inflammatory markers, and new changes on their images. Then we have NK-associated vasculitis, and we have like 3 groups of disorders in this category. During active NK-associated vasculitis patients, they may experience neuropathy, skin rash or ulcers, fever, weight loss. They may have pulmonary symptoms such as cough, shortness of breath, coughing up blood called hemoptysis. They may have sinusitis, chronic sinus congestion, otitis media, ear fullness, hearing loss, narrowing of their airway. They may have kidney problem, renal disease. They may have blood in their urine called hematuria, protein in their urine called proteinuria, and they may have abnormal kidney function as well. They may have as well elevated inflammatory markers. After induction therapy, 6 months, we reassess the patient again. And then, okay, most of them, they will go in remission with our current therapy. But during the remission, they may continue to experience neuropathy. They may continue to experience pulmonary symptoms such as shortness of breath, cough. They may continue to experience hearing loss, narrowing of their airways, and abnormalities of their urine analysis, or even abnormalities of the renal function. At any time during the remission, they may experience relapse, and we will talk about the relapse risk on treatment, off treatment, and then during the relapse or flare, they will get a new neuropathy, new skin rash, new symptoms, new findings, and then their inflammatory markers will be abnormal. And I'm going to give a few examples here. So the first patient presented in June of 2020. At that time, she had cough, shortness of breath, and she was coughing up blood, hemoptysis. On chest images, she was found to have whitish shadows in her lungs. And she was found to have NK-associated vasculitis, GPA, granulomatosis was polyandritis. After induction therapy, and when the disease was in remission, you can see complete clearance of the white shadow after a year during remission. In comparison, going to the second patient, she presented almost with the same symptoms. She had shortness of breath, she had cough, but she was not coughing up blood. And then on chest images, she did have areas of scarring in the small circle, an area of active inflammation and acute inflammation on chest images. After induction therapy, almost a year after, we repeated the images. Afterwards, 2 years after, we repeated the images. She continued to have shortness of breath. She continued to have cough. So if you can see, the areas of inflammation did improve after induction, but the areas of scarring did not improve. And this is what we call it chronic damage. Both are considered in remission, but one of them, the first patient, did have complete resolution of the initial findings of the chest images. The second one did not, and ended up with chronic damage and scarring in the lungs. This is another example. This patient presented with digital finger gangrene, and also he did have renal failure. He was on dialysis with the serum creatinine in the beginning went up to 7.7. After induction therapy, we achieved remission. Unfortunately, we could not save the tips of the 2 fingers, but he did not get any lesions in the other fingers. And you could see that the renal function did improve. So his creatinine went down to 2.5. Now, it didn't go back to normal 100%, but at least he's not on dialysis. And with that, we still call the disease is in remission, because it did not progress further, right? So this is why we called it remission for him.